Hi everyone, Assalamu alaikum. My name is Momo. I'm an intern, and today I'll be talking a lot about disorders of the pituitary, thyroid, and parathyroid glands. So, just starting right off, we'll talk about each gland. So, we'll start with the pituitary and so on. From just as an overview, we'll be talking about these glands over-secreting their hormones, under-secreting their hormones, or structural lesions such as tumors and cancers. And we'll go over them one by one. Just before we start, there are some important concepts from both clinical and patho lectures. First of all, remember that these endocrine systems or endocrine glands happens at multiple levels. So let's take the pituitary, which is what we're starting with. As we know, we have the hypothalamus above it that is controlling the pituitary gland by secreting its own hormones, such as the thyroid, the one for the thyroid releasing hormone. Then the pituitary has its own hormones affecting the actual gland itself, so such as thyroid gland, adrenal gland, and so on. The thyroid gland, for example, these glands will secrete their own hormones. So this is the primary gland, which is what we're talking in this case, the thyroid gland. And they all have their positive and negative feedback effects on each other. So let's say there is the thyroid gland producing its own hormones. It will go back and negatively inhibit the other hormones above it so that there is no overproduction. So our body naturally has a system to keep the hormones at a normal level in this way. Depending on the problem, let's say we're talking about the thyroid gland now, that if the problem is in this gland, that would be the primary problem. We say primary, let's say hyper or primary hypothyroidism. If the problem is in the context of this gland, if the problem is above it, so pituitary gland, something is wrong with it, it's not producing TSH, we will say that the problem is secondary hyper or hypothyroidism, let's say. If the problem is even above that in the control center of hypothalamus, we will say tertiary problem. So primary is the problem in the gland itself, secondary is something above it, tertiary is even something controlling both these glands. So that's an important concept which we'll come to later again. And the second important thing to keep in mind is that these hormones, all of the hormones that I'm going to mention now, follow a cycle. So either 24 hours, they have a pattern, or they can be pulsatile. They can be secreted at certain times of the day. Examples, again, these are examples before we get into the actual bulk of the lecture. So for example, cortisol, testosterone, these are something that has a pattern over the day. This is important because when we have these specific tests to do for these conditions, we need to know that measuring cortisol in the morning, let's say, will be the highest possible reading. And it will show if the gland is overproducing or if there's something wrong with it, rather than measuring it at night when it's already low. So again, keep the time into consideration when doing these tests. And the same way for pulsatile secretions, they can be in like high one time, low one time, depending on the secretion. The third thing is when we have a problem with any of the glands, start with biochemical, so lab tests first, which will, or hormone level first. And then there are sometimes we have confirmation tests. And then after that, after you confirm, you can do imaging to see where the problem actually is. Is the problem in the, in the gland itself? Are there multiple structures within the gland that is causing this problem, and so on. So just keep these in mind before we start. Now, let's start with the pituitary gland. As we know, pituitary gland is the gland in the brain. It's in a depression called the sella turcica, which is in the sphenoid bone. And it has a lot of functions. It is divided into anterior and posterior pituitary gland, which are these names as well. They again, based on the location, it is important to know that it is close. This is the pituitary gland, okay? So it's close to a lot of structures, important structures nearby, which is the cavernous sinus. So you have things like internal carotid artery right there Even in the picture you can see here. And yeah, here. And there are other cranial nerves that are important. So just remember 2, 3, 4, 5, and 6. So 2, as in optic chiasm, is right there. So optic chiasm is an intersection of all the optic nerves that help with the vision. We'll see what the problem is later, but basically the vision, a certain part of our eyesight. So optic chiasm is right there. Cranial nerves 3, 4, 5, 6 are here. Okay, so just remember that if there is a problem with the gland, it can compress or affect any of the structures nearby, which can result in the symptoms that I'll mention. So moving on, so as we said, anterior part, posterior part. The pituitary gland itself is regulated by a higher center in the brain called hypothalamus, right there. And the hypothalamus secretes these hormones: gonadotropin releasing hormone, thyrotropin, corticotropin, all of these hormones, which will then regulate the hormones coming from the anterior pituitary. So again, it will match the names to each other, and that's how they are regulated. So the more the hormones are coming from hypothalamus, the more these are released from anterior pituitary. What about posterior pituitary? Just remember 2 important hormones. ADH, antidiuretic hormone, is stored there. It's not made unlike these. It's made up here and then stored in the ADH, in the posterior pituitary gland, and oxytocin. We'll mainly talk about ADH here and not oxytocin. And this is a figure of the location of the cells within the anterior pituitary. Um, not too important to memorize, but just just for you to know. Okay, so this is a very important table. It shows you the hormones coming from hypothalamus that are regulating pituitary hormones from the anterior pituitary gland, and the cells that produce these hormones from the anterior pituitary. And where do these hormones go to? Their target glands. And this is the negative negative feedback. So if these hormones from these glands are high, they will negatively inhibit the higher up centers. So let's say, for example, corticotropin releasing hormone will stimulate ACTH from the anterior pituitary from cells called corticotropes, which will target adrenal glands to release steroids or cortisol. Okay, so it's the same way. Thyroid releasing hormone, thyroid stimulating from cells called thyrotropes. It will go and target the thyroid gland to release their thyroid hormones, and so on. So somatotropes, mammosomatotrophs are for growth hormones from the anterior pituitary. Gonadotropes are LH, and FSH, which will target the gonads, so ovaries, testes, and so on, which will help with like spermatogenesis, oogenesis, and all the reproductive cycle. This one, lactotroph, is important, and mammosomatotroph, which is a kind of a mixed cell between growth hormone and prolactin. But the main cell for prolactin is lactotroph. Just remember that. Lactin, so lactotroph. Now, there are 2 main inhibitors of the anterior pituitary coming from hypothalamus. So somatostatin is an inhibitor for growth hormone, but it can be an inhibitor for a lot of the other hormones as well. And dopamine is naturally inhibiting prolactin from the hypothalamus, so that keeps it in check as well, as this has no negative feedback. So dopamine is always negative, like inhibiting the production of prolactin and keeping it in check. Surprisingly, just as an important, sometimes you can see it in questions, thyroid releasing hormone can stimulate prolactin as well, based on the proximity of the cells. Now, why are these important? The cell names are important, and knowing how they appear in histology is important, which is why I put B and A. So in normal hematoxylin and eosin stain, in this pink and blue stain, we can see some of these cells will be pink and some of them will be blue. The pink ones are acidophilic cells, so somatotrophs, mammosomatotrophs, and lactotroph will appear pink, whereas the rest, just remember the rest will be basophilic or blue. Now, I say acidophilic, basophilic, but sometimes they can appear as chromophobe, which are no color in the cells. And that's okay. It depends on how many granules or how concentrated they are with these hormones. Okay, so with these hormones. Okay, so we said this is the normal stain. Sometimes we can use immunohistochemistry. So if you want to do, for example, specific to know if this pink is for growth hormone or prolactin, we can target prolactin cells by their antibody and know that this is related to prolactin, for example. So that is immunohistochemistry. It's more specific. There are other types of stains like Ki67 stain, which are proliferation markers. So just to see how aggressive these cells are, or how, if it's a tumor, let's say, how aggressive these tumors are. Okay, now moving on, this is the important part. Pituitary disorders can be, again, hyperpituitarism, so secreting more, or hypopituitarism, secreting way less than it needs to. The main cause for both, if you remember, is pituitary adenoma. Why is that? Because in this case, it can secrete more hormones, but there are some cases where the adenoma or the tumor of the pituitary gland is not functioning. So they will just take up space and they will destroy all the other normal cells nearby, causing hypopituitarism. So it's non-functioning, but still an adenoma. Other causes of hyperpituitarism can be carcinomas, very rare, or other certain like hypothalamus disorders, it's not that important here. And then again, hypopituitarism can be caused by things that damage the anterior pituitary cells. So for example, loss of blood supply, like hemorrhage, or ischemia, stroke, things like that. Ischemic injury, surgery, radiation that will cause damage to the cells, causing hypopituitarism. And then other congenital diseases as well. The main cause, again, non-functioning adenoma. Okay. In your clinical lecture, they divided it into these categories. So tumors, overproduction, underproduction, as we said, the main cause. Cancers are very rare. Some congenital disorders like Kalman syndrome, some inflammation. So inflammatory cells can get into the pituitary gland and cause damage. So these are some examples which we'll touch upon later. And infarction, ischemia, or trauma to the gland itself. Now, I want to mention one thing. Ischemia is like the loss of blood supply to the anterior pituitary, and that can happen in two important cases. One of them is called Sheehan syndrome. You might have heard of it from first year, but basically, the scenario will be a woman giving birth and losing a lot of blood. There was difficulty in delivery, something like that, and the woman will lose a lot of blood. And that will affect or take away the blood supply from the anterior pituitary only, not the posterior one. Why is that? Because in pregnancy, the anterior pituitary gland is very large to stimulate or help with the growth of the baby, help with lactation, milk production, and so on. So the anterior pituitary will be very, very big. So imagine if the woman lost a lot of blood suddenly through delivery, the anterior pituitary gland, which was hyperfunctioning more than normal, will lose a lot of blood, causing hypopituitarism. So it will cause a lot of the symptoms that I'll mention later with hypopituitarism, including deficiencies in all the hormones, the woman being not able to lactate because of lack of prolactin, and so on. Now, apoplexy is something else. Apoplexy is hemorrhage. So let's say there is a tumor of some kind in the pituitary gland. There can sometimes be hemorrhage within that tumor, causing it to rapidly expand and take over that space. And this is a very, very important surgical emergency, which I'll mention now. So, as we said, pituitary adenoma is the most common type of disorder in the pituitary gland. It's almost always benign, and there are many sorts of treatments, either medical or surgical. So they can be functional, which means there is a excess of hormone with the clinical manifestation. It can be non-functional, silent, so they can still cause hormone overproduction, but no clinical symptoms, so silent, or they can be null cell adenoma, which is the non-functioning that I said before. So null cell adenoma is an adenoma, but the cells are not producing any hormone, so no hormone excess, and obviously no clinical manifestation. The only clinical manifestation would be a mass effect. So if the tumor is very big, it will push the other cells in the brain. It can cause a mass effect, like compressing the optic chiasm, cranial nerves, and so on. So that is the local mass effect. Sometimes it can even invade way further. So invasive pituitary adenoma beyond the sella turcica, such as causing seizures and other cranial nerve palsies. So remember 3, 4, 5, 6. So let's say the third cranial nerve is like compressed, you will have some like ptosis and dilated pupils. So ptosis is drooping of eyelids. So depending on the scenario, just remember it can affect the structures nearby. The optic chiasm, if it's compressed, remember the term bitemporal hemianopsia. So the person will start to lose vision on the sides of their like eyesight. So it will be difficult for them to drive, to anything that's coming from their side, it will be hard for them to see. Why is that? Because the optic chiasm provides like vision on those sides. So when that is compressed, that is affected. So as we said, mass effect local can be invasive and pituitary apoplexy. Again, it's a very, very emergent situation, which you treat with surgical, like immediate surgical procedure plus steroids. Okay, and it can cause sudden death. It can cause the scenario will come in that way that the person suddenly collapsed or is vomiting, having all sorts of intracranial pressure, severe headache. Everything, cranial nerves are very, very badly damaged in a short amount of time. So that is the scenario. One of them, just remember apoplexy, and it's an emergency. So you can see it's very like hyper intense because of the blood and the bleeding inside the gland. If the patient is lying supine on their backs, you will find a line like that. So this one is actually it's supposed to be rotated, but there's a line of blood collection within the gland. Okay. So pituitary adenoma again can be, according to size, it can be microadenoma. Just remember number 1. If it's less, it's micro. If it's more than 1 centimeter, macroadenoma. Now, why is that important? It's because macroadenomas are more likely to have that mass effect that I mentioned before. So it will come with more symptoms than microadenoma. Microadenoma, you can find it maybe incidental finding, or if the patient is complaining of the symptoms that I will mention now. So the adenomas are hypo-intense. They are darker in color. So that's you can know that that is an adenoma when you see it in the image. If you see bright kind of structures, these are the normal glands that are being pushed, normal cells being pushed aside by the adenoma. The yellow circle is just showing you the closed structures, internal carotid artery and the cranial nerves that can be compressed as a result of this macroadenoma. Okay, so this is from your patho lecture. Pituitary adenoma is very, in histology, you can easily tell it apart because they will come as uniform cells, a lot of the same cells over and over. That is the sign of the pituitary tumor or adenoma. And the connective tissue that is usually there between the cells is gone. It's not there anymore. It's mostly just cells flooding the slide. This is an example of macroadenoma, an invasive effect. So it's extending beyond the sella turcica into all the other structures of the brain itself. This is again macroadenoma that was treated, and we will see why. In your patho, it's a prolactin adenoma, so prolactinoma that was treated with medical therapy. The hook effect is not that important. I just got it for the sake of completion. Basically, when you have something as big as this, the lab results will be very, very, there can be false reading on the lab results. So let's say prolactin will be in the thousands, but in the lab, it will kind of overflood the cells, overflood the, what do you call it, the test itself. So it won't show as much, or it will show too high in numbers that you will completely miss it. Again, this has to do with the test in the lab. It's not as important, but just know to be careful with macroadenomas. Just remember to test it very well, dilute the sample, and then test the actual increase in hormone so that you don't miss it. I hope that made sense. Anyway, the hook effect is not as important. I just got it because it was mentioned. So moving on, this is a summary of the genetic abnormalities in pituitary adenomas and other structures like craniopharyngiomas and the Kalman syndrome, which is the congenital um, congenital hypopituitarism. Okay, now this is basically memorization, but it's a very in a summarized table. So remember some things that I'll point out. So it can have gain of function of these genes or loss of function that can cause the adenoma. What is important are these aggressive markers. If you see cyclin D1, which is a gain of function, TP53, or RB, so cyclin, TP53, retinoblastoma silence, are all markers of aggressive, pituitary adenoma. So just keep that in mind. HRAS is highlighted because it is the one gene that is causing, if you have carcinoma anywhere, that is the cause of the carcinoma. There is a defect in gain of function in HRAS gene. Okay, and MEN1 is another gene in loss of function, which we'll come to later. It's a triad or syndrome, which can cause pituitary adenoma as well as other adenomas throughout the body. Craniopharyngiomas are WNT gene, and Kalman syndrome are from the name Cal1 or X-linked, which is the most common form. This is pure memorization, but I tried to make it easier for you here in the table. So moving on to hyperpituitarism, which is the overproduction. The most common, as I keep mentioning before, is the prolactin cell adenoma. So the lactotrophs or prolactinoma is causing prolactinoma. The next most common is non-functioning adenoma, so silent or null cell adenoma. And the third most common is growth hormone cell adenoma. Okay. So prolactinoma, let's start with that. In the cases, it will come as the woman having galacturia, woman or men having galacturia, so increase in milk production, and they will notice something wrong, as well as causing hypogonadism. So it will cause things like missed periods, loss of libido, infertility, and hypopituitarism can happen due to the mass effect, so destroying the normal cells around the prolactinoma, okay, depending on the case. So why does that happen? Why does hypogonadism happen? Again, one of the reasons is because of the mass effect causing the cells of the gonadotroph cells are not functioning because of this compression, or it can be due to a direct effect. So if prolactin is high, it actually has a negative inhibition on the GnRH, so gonadotropic releasing hormone from the hypothalamus. So if prolactin is high, GnRH is low, which will reduce the secretion from the anterior pituitary of LH and FSH. So that's why the woman or the men, they will have symptoms that is affecting their reproductive system. And that one is reversible, whereas if it's caused by a mass effect, it's irreversible because it already damaged the cell by the compression. Now, in the histology, you will see mostly chromophobe cells, remember, but prolactin is one of those cells that can appear pink, depending on the granules. So this is an electron microscope. If the prolactin is, let's say, less, it will appear chromophobe cells in the stain. If it's more, if the granules or the prolactin hormones are way more secreted than normal, and much more, it will appear acidophilic or pink. Okay, so depending on the, let's say, the concentration or the amount of prolactin that is produced by the tumor. So you will have, so amyloid, sometimes you will have microcalcifications and so on. and this is the highest, it's the most common, and it is the highest percentage of invasion, around 50%. Okay. Again, if someone presents with these symptoms, check the lab. So check prolactin levels. The normal should be very low, around 20 to 25 in non-pregnant women. But if it's more than that, it is prolactinoma. If it's less than 200, it's still considered microadenoma. If it's more than 200, it's macroadenoma, most likely macroadenoma. The other thing is, if it's less than 200, but still in that category of prolactin overproduction, it can be caused by other things, so physiologic, like pregnancy, or drugs, certain drugs, or stalk effect. So what are the drugs that can cause some overproduction? Are the dopamine antagonists. So like we said, normally dopamine is inhibiting prolactin, right? If someone is taking anti-dopamine drugs, so dopamine antagonists, then there will be no inhibition of prolactin, which is why the prolactin will be overproduced. So this is not an tumor of the gland, it's just that someone is taking anti-dopamine drugs. So that some examples to keep in mind during the questions are things like atypical antipsychotics, antidepressants, antihypertensive like verapamil, and so on. These are listed here. No need to know the specific names, but just remember anti-dopamine drugs. There's another thing called the stalk effect. So without anyone taking these kind of drugs, if the connection between the hypothalamus and the pituitary is compressed by a tumor, by any sort of cell nearby here, this is called the stalk effect. So the inhibition coming from the dopamine is physically blocked, and that's why the prolactin will keep on being produced, which is the mild case of prolactin overproduction. So after you rule out these causes, you can then do, let's say so the people, the case or the patient doesn't have any of these, doesn't take any drugs, for example. So you are left with, let's say, stalk effect, or it can be an actual prolactinoma. You can tell that apart using imaging. So that's when you do the imaging, which is MRI, and you can see this is stalk effect, but prolactinoma will be the one that I showed you earlier. So, oops, yeah, let's go, yeah, like this, for example. And then you can stain it to see which cells are actually produced, which in this case are lactotrophs, okay? So the treatment for prolactinoma, the only pituitary adenoma, that the first line will be medicine, like medication. So you can easily reverse this by giving them dopamine agonists. Whether they're taking this or not, you can give them dopamine agonists such as cabergoline, which is preferred, or bromocriptine, which will again resume the inhibition of prolactin, because dopamine usually inhibits prolactin, and that will help with the clinical manifestations. If, let's say, it's not treated, you can go into surgery, but most of the time you can stop with the medication. Okay, now moving on, growth hormone producing adenoma, which are somatotroph adenoma. Most of the time they are macroadenoma. It came in a question, so I just put that here. Again, from the name, growth hormone, if it's overproduced, you can immediately know that it produces overgrowth of soft tissue, bones. So you can see the facial features here, the hands, the shoe sizes, they're being changed. There's bony overgrowth as well as the heel pad, the soft tissue being like grown a lot more. So you have a lot of other problems. It can even cause organomegaly, so cardiomegaly, which is the #1 cause of death in these patients. And it can cause, again, big hands. The hat sizes can change because of the head size. And other symptoms like excessive sweating, diabetes, muscle weakness, hypertension, heart failure, and obstructive sleep apnea due to, again, obesity and increase in weight gain for these patients. In histology, you will see growth hormone is the second one, the second cell, somatotroph, that can be acidophilic. Sometimes, again, they can be chromophobe depending on the saturation. So if they are less, like if they are producing but not as much from the gland, then it will be chromophobe. If there's a lot more glands, a lot more cells, a lot more production of these growth hormone, it will be acidophilic, okay? But never basophilic, these two, prolactin and growth hormone. Okay, so someone, let's say, came with these clinical symptoms, so increase in their sizes, increase in, let's say, weight gain, and so on, you can check their insulin growth factor 1 level. This IGF-1 will be very, very high, and that will be your diagnosis for growth hormone producing adenoma. And again, you can move on to imaging, pituitary MRI, to confirm that it's an adenoma. So it's a problem with the pituitary gland and not, let's say, the liver producing it. So which is, again, the liver usually produces this, but it's controlled by pituitary. So pituitary MRI will confirm the location of the tumor. So if you need more confirmation in between, you can do growth hormone suppression test. And in this case, because it is overproducing, it will not be suppressed. That is your confirmation. Other tests such as visual field test, thyroid exam, you can do echocardiogram because of these, because of the increase in heart size, or colonoscopy because it can increase in tumors elsewhere. So colon cancer, for example, because it's growth produce like growth hormone. So it has a growth effect even on cancers. So you can do these type of tests. Again, important treatment. The first line, now that we finished prolactinoma, first line of treatment will be surgery. So you approach the adenoma through the nose, so transsphenoidal approach, and you remove the pituitary adenoma. Medical therapy can help, so inhibition of growth hormone using somatostatin analogs, dopamine agonists can sometimes help as well, and growth hormone receptor blocker. So pegvisomant is blocking the receptor itself, which will help with the clinical manifestation. Sometimes you can use radiation therapy. Again, if these fail, one important thing to note is that these are all reversible, but the bony changes that happen in the face, in the hands, are irreversible because the bone will not go, it will not shrink back in size even after you treat the adenoma. The third one is ACTH producing tumor, which is, again, corticotrophs. This has a specific name called Cushing syndrome. And most of the time it is microadenoma, so small sized tumors, but it can have clinical manifestations, okay? So Cushing syndrome can be caused by an increase, it's a term for increase in cortisol level. Cortisol helps with our blood pressure, with our, a lot of things like weight, metabolism, stress levels, and so on. If the problem, so the most common cause of Cushing syndrome is if someone is taking externally, like steroids, so drug induced. So if someone is taking excess cortisol, that is the most common cause. Other types of causes can be pituitary adenoma in this case, or adrenal tumors, or ectopic. So somewhere else, like some other tumors, let's say in the lung producing ACTH. So that's ectopic. If the problem is the adenoma, pituitary adenoma, like in our case, we call this Cushing disease. So if you hear disease, that is specific for pituitary adenoma producing ACTH. If it's Cushing syndrome, it's more general, so it can be caused by any of these 4 reasons. What are the symptoms of Cushing? So increase in cortisol can cause all of these symptoms. So increase in our blood glucose, so hyperglycemia, weight gain, moon face is a common thing, like hump, having like a buffalo hump because of, again, the fat, increase in fat and increase in obesity, fat deposits. It can cause even reproductive like symptoms, increase in hair, increase in acne, and osteoporosis because of the weakening of the bones. And these kind of stria or markings in the stomach. So again, it's because of skin changes due to the ACTH. In the histology, they will appear. Now we move to basophilic if they are very, very much concentrated, densely granulated, or sometimes occasionally chromophobe, so no color in the cells if you stain them. They can also be PAS positive, which is another stain that stains the carbohydrate. So it's very pink, and because of so ACTH is related to melanin as well, which is the skin color. So if they are increased because of this tumor, they can also have PAS positive stain as well. Just remember that. Another interesting thing is Nelson syndrome. They might bring it. So if let's say someone had Cushing's syndrome due to adrenal gland tumors, so bilateral adrenal gland is producing so much cortisol. If um, in order to treat this, someone underwent removal of these adrenal glands, so bilateral removal of adrenal glands, the body is suddenly lacking cortisol, which it was not used to before. So the pituitary gland, which is still intact, will start producing ACTH in order to make up for this loss. So this Cushing disease happens because you removed another source of Cushing syndrome in the first place. So you remove the adrenal glands, then the corticotroph starts producing more, causing this ACTH pituitary adenoma. Okay, so that is Nelson syndrome. And you would have to treat this again as a case of Cushing disease, even though you just treated it before. In that case, you can see hyperpigmentation. Remember, melanin will be increased with this ACTH, causing like browning of the skin or darkening of the skin. Now, for diagnosis, if you have these clinical, let's say, symptoms, you go to screening tests. So you do things like measuring cortisol level at midnight because it's supposed to be at its lowest, and 24-hour urinary free cortisol. Another test is called low-dose dexamethasone suppression test, which usually suppresses the cortisol. Okay. In Cushing syndrome or Cushing disease, they will all be not suppressed. So it will be high here, high here, high here. So high cortisol levels because of overproduction. If two of these three screening tests is positive, move on to the next step, which is confirming or trying to see what the problem is. So measure ACTH. Now that you know that cortisol level is high, you can measure ACTH to see if that cortisol is due to ACTH increasing it or if it's just being secreted on its own. So if ACTH is causing that increase, ACTH will be high, obviously, and we call this ACTH dependent disease. So it can be due to pituitary adenoma, so Cushing disease, or it can be an ectopic production of ACTH that is producing cortisol increase. In other cases, if ACTH is not high, if ACTH is, you see here, this is another diagram. If it's low, it will be ACTH independent Cushing syndrome. So things like adrenal glands producing a lot of cortisol themselves without ACTH stimulating it, or someone taking externally drugs, corticosteroids or cortisol. Okay, so measure ACTH to separate the two causes. If it's high, it's ACTH dependent. You can go on to do MRI of the brain. You can do high dose dexamethasone suppression, again, another test, or cortical releasing hormone stimulation, and so on. If it is ACTH independent, so let's say, or actually, if it's ACTH dependent, but ectopic, so you are suspecting tumor somewhere else in the lungs, somewhere else in the body, you can do, that's for B. So you can move on to imaging of CT chest or CT of pan-CT, so CT chest, abdomen, pelvis, to look for the source of tumor causing the cortisol. If it's CT, let's say ACTH independent, so adrenal glands are secreting cortisol, and you want to look at the adrenal glands, again, you can do CT adrenal, CT of the adrenal glands, which you will see here. I hope that made sense. So you can either have cortisol being high because on its own, or because of ACTH produced from the brain or from ectopic place. Now, let's say that because our focus is Cushing disease, which is the pituitary gland adenoma, and we proceeded to do pituitary MRI, okay, and we saw that the gland is increased in size. There are other sort of tests to confirm if the pituitary adenoma is really ACTH producing. So you can do high dose dexamethasone test. High dose dexa, this was low dose. In high dose dexamethasone test, if it's a pituitary gland, it will be suppressed. Okay, remember in low dose it will not be suppressed, but if you're using high dose, it will actually be suppressed, even if the problem is in the pituitary gland. And again, the confirm the most I guess you can say confirmation you can do after the MRI is something called inferior petrosal sinus sampling. So you basically sample the blood or the veins that is draining away from the pituitary gland. So if in those places the ACTH is high, you can immediately know that the pituitary itself is producing all these ACTH, right? So you are directly measuring from the inferior petrosal vein near the gland. That will confirm Cushing disease, which is what we see here. So if it is high in that blood, it is pituitary tumor. If it's low, that means it's ectopic. The ACTH is being produced from somewhere else in the body, like the lungs. So you proceed with CT chest. If the ACTH, again, this ACTH is low, it's independent, you can do imaging of the body to search for adrenal gland tumors, or ask them if they are taking, let's say, steroids. Okay, I hope that was clear. Now, the treatment for ACTH producing tumor, just remember the symptoms and the screening test. How do we categorize it and how do we image it based on our differentials? Okay. Now, the treatment for pituitary adenoma of ACTH is surgery, always surgery, except the prolactinoma, or medical therapy to block the synthesis of cortisol, which you will take in pharma lectures. Um, and another important thing is remember that with all these treatments, there will be a huge loss of cortisol that the body was used to before, right? So to reduce this loss of, to reduce this huge like impact on the body, you have to give the patient some high dose steroids to prevent them going into adrenal crisis, which is the complete loss of hormone cortisol. So let's say you are doing surgery, you plan them for surgery. It's better to give them high dose steroids first to prevent this. Even after the surgery, keep them on high dose steroids so that the body slowly gets used to the normal level of cortisol rather than it being completely deficient in cortisol. Okay, so that is an important point. Okay, the TSH producing adenoma in the brain, the pituitary gland, is the least common, and you can know immediately by the symptoms that we'll talk about in hypothyroidism. So they will have fatigue, constipation, cold, feeling of being cold all the time, and so on. How do we how do we kind of like uh, manage this or approach this is we do lab tests. So we check the TSH level, thyroid hormones, and then do pituitary MRI to localize it. Treatment is again surgery and medical therapy if you want to inhibit if that doesn't work. Okay. So question one, because this is a recording, I won't read it. Just pause the video and I'll explain what the answer is. So pause the video now. Basically, this question is talking about a woman having all the symptoms of, uh, like, for example, not breastfeeding, never pregnant, no menstruation. So hypogonadism, right? Her reproductive system is down. But there is a mass in the MRI in the sella turcica, so we are suspecting pituitary adenoma. Which of the following complications is she most likely to have? So like we said, the most common type of tumor that can cause this sort of symptom, plus galactorrhea, so increase in milk production, is prolactinoma. Prolactinoma can cause other reproductive, like hypogonadism, like infertility. So that is the answer for this question. It will not cause acromegaly, like that is caused by growth hormone. It will not cause hyperthyroidism, for example, or neurologic dysfunction. Most likely, infertility will be affected. What is the next step in management for prolactin? Now that you are 100% sure that it is prolactinoma, you start with um, medical therapy first, right? So cabergoline, dopamine agonists to inhibit the production of prolactin. Then if that doesn't work, you can proceed to surgery. So question number 2, you have a woman coming after a huge blood loss after delivery, and these are the lab results. You can see that some of them, mostly they are normal, and over the next few months, her menstrual cycles are affected and so on. So what is the most likely cause of this is Sheehan syndrome. So Sheehan syndrome is loss of blood after delivery, which will cause hypopituitarism of the pituitary gland. So what choices here support hypopituitarism? So it's not this one because that's from the hypothalamus. And we said Sheehan syndrome only affects anterior pituitary gland, anterior. So it's not also oxytocin, not antidiuretic from the posterior pituitary. So the answer is failure of growth hormone stimulation, failure of prolactin hormone, failure of thyroid stimulating hormone, TSH. So any anterior pituitary hormone will be affected by Sheehan syndrome. Which of the following is associated with aggressive pituitary adenomas? Remember, the genes. So we said one of them is retinoblastoma silencing. So loss of function, retinoblastoma gene. It can be TP53 or cyclin D1. Cyclin D1 gain of function. Okay, so these three are the aggressive type of pituitary adenomas. Okay. Wait, so here I mentioned AIP is for growth hormone. It's not aggressive. And MEN1 was also in the loss of function table, which we'll come to later. It's not aggressive as well. So moving on to hypopituitarism. So the complete opposite. You will have decrease in the glands from the anterior pituitary, and the clinical manifestations will be the opposite of what we discussed before this. So let's say there is necrosis, ischemia, Sheehan syndrome, apoplexy, anything can cause decrease in all these hormones from the anterior pituitary gland. So growth hormone, gonadotropin releasing hormone, TSH, ACTH, prolactin, and the symptoms will correspond to that. So growth failure, gonadotropin releasing hormone will have lack of this will have reproductive like dysfunction, loss of hair, amenorrhea, infertility, which we saw in hypogonadism with prolactinoma, right? So that was caused by prolactin decreasing the GnRH. But here it can be, again, these are just the symptoms if this is hypopituitarism, okay? TSH, hypothyroidism, ACTH, hypoadrenalism, and so on. Okay, so like we said, the most common cause of hypopituitarism is, again, pituitary adenoma, but non-secretory, non-functioning. So it will just damage the cells around it based on this tumor, okay? This is a summary, and most of the time we just replace, if for hypopituitarism, the treatment is just in replacing these hormones. So you can easily give, for example, thyroxine for thyroid deficiency, steroids for ACTH deficiency, and so on. Except, I guess, prolactin, you don't really replace it. You don't really need to. And ADH is the hormone from posterior pituitary gland. You can give desmopressin, which is a synthetic form of ADH. Okay. When do you need to operate? If that doesn't work, or if there are severe symptoms like severe headache, optic chiasm compression, apoplexy is a neurosurgical emergency, or recurrence of the tumor. Now, the first one we'll talk about is, again, in this category of pituitary adenoma, not functioning, but causing deficiency in ACTH. So ACTH cells, the corticotropes are being affected, and we call this central adrenal insufficiency. and low ACTH. So all the symptoms of Cushing disease will be the opposite here, or Cushing syndrome as well. So fatigue, they will have weight loss instead of weight gain. There will be nausea. They will have a feeling of vomiting. Maybe can be as a mass effect from the adenoma. They will have hypotension instead of hypertension, and they will be very weak and ill looking. So they will be very thin and so on. Complete opposite of Cushing syndrome. What can we do to kind of diagnose this is you can do ACTH stimulation test. So you can usually this test by injecting a synthetic form, synactin. If you inject this, it should increase the ACTH levels. But because this is non-functioning, it will be suppressed, so it will remain low. And that's how you know that the pituitary gland is not working and it's secreting very, very low levels of ACTH. And another thing is insulin tolerance test. You can also do that to kind of diagnose this case. The treatment for this, if you have low ACTH, low cortisol, you treat it with giving steroid, right? Steroid replacement. Remember, if someone is taking too much steroid, it can cause Cushing syndrome. So it's the complete opposite we're talking about here. So you can treat this condition by replacing steroids, and they should always have a medical, like a bracelet or something to show that they are always taking steroids, because in case of emergency or trauma or stress or illness, or let's say an accident, you want to be able to give double their normal steroid, right? So you can double the dose that they are usually taking, because in times of stress, you need more cortisol, and they are already used to having taking steroid from outside for this condition. Okay, so they should wear this so that professional, like doctors, can know when to give or who to give it to, who to give more steroid replacement in cases of emergency. Okay, so because if they don't give that, then they will go into adrenal crisis, which we don't want. Okay, the next one is hypothyroidism from the pituitary adenoma, non-secretory, non-functioning, so low TSH. All the symptoms of hypothyroidism will be present here. And oh yeah, and in the testing again, the hormones will be low. Sorry, I forgot to mention this one. I made a mistake here. This is TSH producing adenoma, so it will be the opposite. So they will have hyperthyroid symptoms, not hypothyroidism. Okay. This one is hypothyroidism, and the complete opposite you can treat with levothyroxine, and yeah, by replacing the thyroid hormones. Even in this case, always start with steroid therapy, because if the patient is deficient in both hormones, both ACTH and TSH, start with steroid first to prevent the adrenal crisis. Now, all these pituitary adenomas that are non-secretory can present with local mass effects. It can present with these deficient symptoms, or it can be an incidental finding that they find on MRI. Moving on, if let's say the person has growth hormone deficiency from the pituitary gland, you will have the opposite. So in children, it will have stunting of growth, but in adults, it will be fatigue, obesity, reduced muscle mass, and so on. How do you test it? You test with insulin growth factor, again, lab test, it will be low, or other confirmatory tests, because this will not rule it out, are insulin tolerance test, glucagon stimulation test, or growth hormone releasing hormone test. All of these will have no growth hormone increase when it normally should have, because this is deficient from the pituitary gland. It's not functioning, it won't increase due to these stimulation tests, okay? For treatment, you really don't need to treat that in adults, because you can treat it, but benefits of treatment will have these. It depends on the clinician or the physician. Usually, it will not be that severe, because growth hormone in adults being deficient, it will not cause that severe symptoms. Keep monitoring IGF-1 levels as well. Important thing, remember I said growth hormone can increase the growth of cancers like colon cancer and so on. So you always have to not treat people who have cancer. So in this case, so again, just to be clear, growth hormone can increase the stimulation of cancers, right? So in someone with growth hormone deficiency, you don't growth hormone deficiency and with the tumors or active cancers, you don't want to increase those growth by treating them. So in that case, no need to treat these type of people. So active cancers, prostate cancers, you do not give them hormone therapy because they can just worsen the cancer. Okay. Um, okay. Now let's move to the next one, which is that diabetes insipidus. So that one is a low ADH, so low antidiuretic hormone from the posterior pituitary gland, causing symptoms of the person drinking too much water, going to the like urinating a lot, and weight loss. The normal function of ADH is to reabsorb water, right? So we will say that in cases of low ADH, the person will lose a lot of water and is unable to reabsorb. So they will be very thirsty and they will drink a lot of water to make up for that. What are the causes of this? It can be due to surgery or like any trauma to the head, pituitary surgery, complication that can cause like compression or damage to the ADH, the posterior pituitary, which is storing the ADH. It can be due to other stock like compressions or conditions of the gland here, such as craniopharyngioma, again, inflammatory conditions, apoplexy can cause compression of the posterior pituitary. And like, see how I mentioned these conditions and not macroadenomas, because macroadenomas rarely compress on the posterior side. So we said macroadenoma can cause mass effects most of the time, but very rarely that it will cause compression of the posterior pituitary. Other causes will be more prominent. So in the labs, you will have dilute urine because the person is losing a lot of water, losing a lot of salt, like with the water itself. So they will have dilute urine because the water loss is way more. And the urine osmolality will be low, which means it's very low and it's the same thing as dilute urine. Whereas in the blood, it will be high hypernatremia. So you have lots of salt left in the body because you are losing the water. What is remaining will be like sodium. So that's why these will be the lab. And you can do water deprivation test, like keep the patient away from water, and that is when the symptoms come so much more. And even in the lab tests, because they are losing water. Okay. Now, treatment for this is again the synthetic form, desmopressin, to make up for the ADH loss. So all of these symptoms, this is again showing loss of posterior pituitary gland, which is the place of storage for ADH. So all of these, just remember, deficient hormones, you replace them with their respective hormones to make up for these symptoms. Okay, now lymphocytic hypophysitis is another condition, inflammatory. It's not a tumor, but it's more like um, inflammatory cells invading the pituitary gland, whether anterior or posterior, which can cause these above symptoms of pan-hypopituitarism or specific hypopituitarism, as we mentioned. So if you see in the case during or after pregnancy, that is most likely, so during or after pregnancy with lymphocytes with symptoms of hypopituitarism like ACTH deficiency, ADH deficiency, like we mentioned. So ADH deficiency is diabetes insipidus, ACTH deficiency are the opposite of Cushing syndrome. So things like hypotension, weight loss, and so on. So just remember that all of these together, it will lead, and along with severe headaches and this MRI picture showing the inflammatory cells invading, will all lead to the diagnosis of lymphocytic hypophysitis. And it is different from adenoma, and they can tell, like the surgeons can tell that when they examine it. But other than that, like regardless, you treat it with steroids. It's inflammatory condition, no need to do surgery to remove it, and hopefully that will reduce the symptoms of hypopituitarism. Now, there are other mass structures that can invade the pituitary gland. So they can be non-neoplastic or neoplastic. Non-neoplastic, the most common is, let's say, the cleft, like Rathke's cleft cyst, which is the anterior pituitary part being like there is a cyst or some sort of mass that is not neoplastic. So all of these are examples, okay, of cysts, most likely cysts, mucocele, and so on. Neoplastic cysts or cancerous or tumors, let's say, that are cystic in nature, so craniopharyngioma, astrocytoma, and meningioma, so tumor of the meninges, so the covering of the brain. These two are for craniopharyngiomas. So let's talk a bit more about this. Craniopharyngiomas are manifest, like they are not, I guess you can say they're very aggressive, even though aggressive, they are benign to tumors, but they're aggressive, okay? So craniopharyngiomas arise from the anterior pituitary remnant or the Rathke pouch remnant. They are slow growing and again, remember this genetic mutation WNT from the table. They present with hypopituitarism, pan-hypo, or specific to diabetes insipidus, so ADH deficiency or pan-hypopituitarism. In the gross, like how they appear grossly is they have both solid and cystic components, and even in the histo slide you will see like papillary projections, most likely squamous cells all around. It's very aggressive. It's not normal looking at all. And yeah, this is a papillary type, but it can be other types as well. You will most likely see solid and cystic components. So solid, like squamous epithelial cells everywhere, or cystic components, very, very large spaces. And this one is a case of craniopharyngioma. Once you resect it, you can know, and once you rule out all the other causes. Okay, so craniopharyngioma can cause panhypopituitarism, like we kept mentioning before. Okay. Other causes of hypopituitarism can be congenital, which is Kalman syndrome. Kalman syndrome is from birth. The patient or the person will have hypogonadotropic hypogonadism, so their GnRH is affected, thus leading to LH and FSH deficiency. So they will have problems in their reproductive, in their sexual characteristics, and so on, plus anosmia. So loss of smell is very, very important. It has to be there for it to be Kalman syndrome. Why is that? That's because the olfactory bulbs that are supposed to be here for the smell, they are not developed in Kalman syndrome as they normally should be. The most common mutations, like we mentioned before in the table, and this is how they will present. They will have everything will be, so it's the same as gonadotropes being low, right? So they will have delayed puberty, delayed or no menstrual cycle in females. They will have a long, tall body. Why is that? Because they have lack of estrogen. So they will keep growing without the closure of the bones, the epiphyseal plates, which are usually done by estrogen. Now, testicular size in male will be less, breast size in females will be smaller, infantile genitalia, so everything will be kind of poorly developed. Lack of facial hair, body hair, and gynecomastia can happen in males, which is like a growth of the breast in males. There can be other symptoms with the syndrome, so cleft lip, syndactyly, which is multiple fingers, unilateral, again, these are other symptoms. This is mirror hand movement, which can come sometimes with this syndrome. And the treatment for this is you treat the deficiency. So the deficiency is in the GnRH or the gonadotrope hormones, LH and FSH from the anterior pituitary gland, right? So GnRH is from the hypothalamus. So the problem here is hypothalamus with Kalman syndrome, causing deficient LH and FSH from the anterior pituitary. So the treatment for this is you can give the hormones themselves, cover the deficient hormones, so testosterone, estrogen, FSH, again from the anterior pituitary, or you can just give GnRH, the hypothalamus, the hormone from the hypothalamus itself. You can just inject that in a pulse-like manner so that it stimulates the other cells, the anterior pituitary and FSH. Okay, so you can treat any of these. You can tackle this by treating any of these hormones and replacing them. Now, question number 4, pause the video if you want. If someone comes with headaches, polyuria, visual problems, so mass effect, and symptoms of diabetes insipidus with high sodium level, so in the body, and their prolactin is also high, which of the following is the most consistent with these findings? So we said that if someone is coming with mass effect and diabetes insipidus, this is hypopituitarism of low manifesting low ADH, right? So that can be caused by a lot of factors. In this case, the mass is removed and histology shows squamous epithelial elements of lipid-rich debris containing cholesterol crystals. Just so you know, that is specific for craniopharyngioma. And just to add to that, you have calcified, partially solid, and cystic mass. That is craniopharyngioma. Okay, they can cause mass effect. They can cause hypopituitarism. They can cause prolactin being high. Why is that? If someone knows, that is because of the stalk effect. So the craniopharyngioma is compressing the stalk that is physically removing the dopamine inhibition. So the prolactin is free to kind of being overproduced, but still less than 200. Okay, I hope that makes sense. So stalk effect of prolactin. So this question, I'll answer it right away. Someone is coming with these symptoms. Overnight dexamethasone suppression test is done, and it shows lack of suppression. So the cortisol is very, very, very high. So we know that it can be ACTH, so Cushing syndrome, basically. Late night salivary cortisol is also elevated. And what do we do next? We measure ACTH. So after measuring ACTH, after doing the confirmation test, the MRI, the inferior petrosal sinus sampling from the brain itself, they saw that there was no, there is no increase in ACTH from the inferior petrosal sinus. Sorry, I should have mentioned here that the ACTH was elevated. So ACTH is elevated. It can go either Cushing disease, so from the brain, or ectopic. We ruled out the Cushing disease by this, right? So there is no ACTH found in the inferior petrosal sinus. So that means that the ACTH is being produced somewhere else, ectopic. So what do you do next? According to that, the imaging should be maybe somewhere in the lungs, right? So lung cancer can cause ACTH production ectopically. So chest CT is your answer. Okay, so you ruled out pituitary gland tumor. So you don't need to do high dose DEXA, MRI of the pituitary. Adrenal is ACTH independent, and urinary cortisol will not make a difference in the management. So you need to proceed with the right imaging, which in this case is chest CT. Now that we finished with pituitary gland, we'll move on to thyroid gland. So thyroid disorders. This is the gland. Normally, it's in our neck here, and it can cause its function is to help with our basal metabolic rate, and so on. So the normal thyroid has follicles. You can see follicular cells here, and a lot of pink structures called colloid. And in between these follicular cells, you have parafollicular cells, which will release something called calcitonin. So those two cells are present in the normal thyroid gland. The thyroid follicular cells are the ones that will produce thyroid hormones, so T3 and T4. And we'll see, yeah, so this is how it normally looks. But if it's overproduction of thyroid hormones, the epithelium will completely change. It will be taller cells, and it will look like it's very much more active. The cells are more active in producing these hormones. The function is, again, increases basal metabolic rate. If the problem is in the thyroid gland, we will call it primary. If it's in the pituitary, secondary. If it's in the the hypothalamus, tertiary. Okay. This is the normal production of thyroid gland like hormones. So this is the follicular cell you see here. This is one follicular cell, and that's the colloid. This is the colloid. Okay. Colloid is just the accumulation of the structure. In this case, the normal one is called thyroglobulin. That is a structure that is found in the colloid. So normally you will have the follicular cells kind of making thyroglobulin and secreting it into this pink space. Then iodine is pumped inside the colloid as well. Iodine is oxidized and then combined with the thyroglobulin to make either T3, so 3-iodine with the thyroglobulin, or T4, thyroxine. Okay. So these are just the hormones and the normal structure. Okay. So thyroxine T3 and T4 are the normal thyroid hormones that are secreted in the excreted in the blood, or secreted in the blood and goes all over the body. What is important is the thyroid function test. So whenever there is a problem in the thyroid, there is a thyroid disorder, the first test that you always have to do is TSH. So TSH is the thyroid stimulating hormone. If it's high, if it's low, it will differentiate a lot of the other causes of hyper or hypothyroidism. The next important test is free T4. So once you compare these two, you can know where the problem is. If TSH is high and free T4 is low, that means it's hypothyroidism. But where is the problem? The problem is from the gland, because T4 is low, right? So the TSH is high to stimulate, to kind of compensate for that. So the problem is here. If the problem is in the pituitary gland, then that means TSH will be low, say secondary hypothyroidism, T4 will be low, right? So low and low will be secondary problem. If it's secondary hyper, then TSH will be high, T4 will be high, and so on. There are also, you can do other tests, which I'll get back into. So thyroid antibodies according to autoimmune diseases, or thyroglobulin, which is the normal substance found in the thyroid. But because in cases of cancer, they can increase, you can measure it to see if the cancer is there or not. Okay. Consider some factors when doing the thyroid function test, like age, pregnancy, if the person is taking supplements or other drugs. And again, I'll go into this in a bit, but another important thing is in thyroid function test, if someone is in a case scenario, if someone is in ICU or in a critical condition and they have all their thyroid hormones are low, this can be due to something called non-thyroidal illness. So because the body is in a critical condition, it's in stress, it's trying to reserve its energy for the important function of the brain, of the heart, and so on. So it tries to reduce the basal metabolic rate by decreasing its own thyroid hormones. The only thing that will be high in this case is reverse T3, so RT3. That is an inactive state of the thyroid hormone. So that will be high, again, inactive. Why? Because you want to not cause more stress on the body that is already facing this amount of stress or critical condition. Okay, so that sick euthyroid or non-thyroidal illness, RT3 will be high, the inactive form, whereas everything else will be low as the person is sicker, gets sicker and sicker. Okay. So thyroid disorders, most of the time, you will see that it's more common in the females than males. Anything we talk about here is more common in the females. It can be hyperthyroidism, overproduction, thyrotoxicosis, again, overproduction, or hypothyroidism. Okay. so less production of the thyroid hormones. Structural lesions, again, can be cancerous or non-cancerous, which we'll get into later. Now, hyperthyroidism can be primary cause, so it can be due to autoimmune condition, like diffuse gland hyperplasia, so all of the gland is affected, or maybe some part of the gland is affected, so they are hyperfunctioning adenoma. It can be multinodular or one nodule. It can be caused by too much intake of iodine, can be from birth if the mother has autoimmune disease of Graves. Secondary can be from the pituitary problem. So pituitary adenoma is secondary, and so on. Thyrotoxicosis can have other other causes, and we'll get into this in a bit. So these are problems with the thyroid gland, but things like infiltration of cells within the thyroid. So it's not autoimmune, not within these conditions, okay, which I'll explain. The hypothyroidism can be primary from the gland itself, so developmental, like genetic mutation. It's resistant to TSH, let's say, so it's not producing any thyroid hormones. It can be post-surgery. It can be autoimmune, which is the most common cause, Hashimoto, and iodine deficiency in the diet, drugs like lithium, and congenital. Secondary will be from the pituitary level, so low TSH, low thyroid hormones. The ones in red box, they are actually thyroiditis, which is inflammation of the thyroid gland. And the inflammation can be caused by viral illness and so on. But before that, let's talk a bit more about hyperthyroidism, overproduction of thyroid glands. The clinical symptoms will be everything of the basal metabolic rate will be increased. So they will have rapid pulse, tachycardia, tremors, the eyes will be affected, the skin will be warm, the temperature will be high, they will have diarrhea, weight loss, and so on. This is what I was talking about. This is important to check and to know where the problem is. So let's say euthyroidism is normal TSH and T4. If the, let's say, TSH is low and T4 is low, then that means the problem is in the pituitary gland, causing secondary hypothyroidism. So low TSH causing low T4. If the TSH, if the TSH is low, right, and the T4 is high, right there. So if T4 is high, that means it's producing more. So we can categorize this as hyperthyroidism. Now, if the problem is in the gland itself, we will call primary, and that is why TSH is low, because it is trying to suppress the thyroid from the pituitary, right? But it's not working because the problem is in the thyroid gland. Opposite, likewise, if TSH is high, so let's start with T4 first. T4 is low, then that means hypothyroidism. But if the TSH is high, that means the pituitary is trying to stimulate the production. So the problem is in the thyroid gland. If the T4 is high, hyperthyroidism again. But in this case, if TSH is also high, then that means the problem is from the pituitary gland. So secondary hyperthyroidism. I hope that made sense. And T4, so another thing, they can be subclinical. So let's say that, so T4 is normal, but there's something wrong with the TSH, then we will call it subclinical. So it's not manifesting, like there's no clinical symptoms, but it's just in the TSH lab level that is either low or high. So we will call it subclinical either hyperthyroidism or subclinical hypothyroidism. That can be caused by a number of factors like pregnancy and so on, or certain drugs. So the most common cause, or let's say the most important for this lecture, is hyperthyroidism due to grave disease or autoimmune condition. So that is where you have a diffuse So because it's autoimmune, it will affect the gland diffusely. It will be very, very enlarged, and they will have a triad of symptoms. So diffuse gland is one, and they will have exophthalmos, which is the eyes kind of bulging out, and we will see why, and pretibial myxedema. So there is swelling in the legs, in the soft tissue of the legs. Now, why is that? So these three triad is grave disease. Okay, why is that? It's because, again, autoimmune condition, you have an antibody that is in the that is kind of stimulating or simulating the effect of TSH. So you will have three types of antibody: thyroid stimulating immunoglobulin, or thyroid growth stimulating, or TSH binding inhibitor immunoglobulin. Main idea is that this antibody is copying the effect of TSH. Okay, so it is copying the effect of TSH here, and it attaches to the thyroid and overproduces the thyroid hormones, even though it's not TSH, right? It's just an antibody kind of copying TSH. So in this case, the thyroid hormones will be high, T3 and T4 will be high, TSH will still be low because from your body it's trying to suppress it. The anti-TSH antibodies will be high because they are the problem. They are the ones causing the increase in thyroid hormones. Now they will stimulate thyroid growth and T4 release, and they are the ones who cause something to increase as well. So thyroid hormones, when they increase, they react with glycosaminoglycans, so soft tissue, connective tissue of our body, and that accumulates in certain places, like the eyes, which will cause bulging, or the legs, which will cause myxedema, which is swelling. Okay. So the eyes can have many manifestations. They can be staring gaze, so it's as if the person is staring at you because it's very big, or there is delay in the lid closing down because of the bulging, so lid lag, or exophthalmos, which is the bulging of the eye. And in histology, you will see very, very tall columnar cells. Remember, it's nothing like the normal cuboid cells of the thyroid follicular cells. It's very tall cells. You have scalloped margins, we call it. So you can see that it's very active. It's trying to secrete a lot of colloid, a lot of thyroid hormones, which is why it makes the gland look very active, with lots of spaces and a high epithelium, columnar epithelial cells. So in Graves' disease, why do we have the exophthalmos? Again, because of the inflammatory cells, because of the antibody um, kind of increasing the amount of cells, the lymph, like the, what do you call, inflammatory cells, and they will attach and cause accumulation of glycosaminoglycans or GAGs, and they will accumulate behind the eyes. They will cause hypertrophy of the eye muscles and so on. They can also be edema because of the inflammation, and that will all cause exophthalmos, or the bulging of the eye. And again, even fatty deposits or fatty cells can increase. All of these reasons or causes are very important to know why the exophthalmos happens, and they can be asked in an SAQ or so. So try to memorize them. And that causes the bulging of the eyes. Okay. So moving on to hypothyroidism, which is low thyroid hormones. So everything will be low. The body will be slow, like slowing of mind and body. There will also be swelling due to edema, slow pulse, constipation, cold, the person feeling cold all the time. There is delay in reflexes, obesity, and menstrual irregularity. The mixed edema is again because of accumulation of glycosaminoglycans in the skin, in the soft tissue, and so on. So this is after treatment. You see how the swelling reduced completely, and this is just how easily you can treat hypothyroidism just by replacing the thyroid hormones, like we mentioned before. The most common cause of hypothyroidism in someone, in a female, let's say, that has family history of hypothyroidism and with no trigger, we call this again autoimmune hypothyroidism or Hashimoto thyroiditis. The clinical manifestations will be these, and in the histology you will see the thyroid gland is enlarged again because it is autoimmune condition, so it is trying to produce like the TSH. So okay, let's take this step by step. So Hashimoto hypothyroidism, you will have low T3 and T4 because of the autoimmune disease, right? So the TSH will be high because they are trying to get the thyroid to work. If the TSH is high, it will go to the thyroid and stimulate growth of the thyroid cells themselves. So that is why there is, again, diffuse goiter, we call it, or diffuse enlargement of the thyroid gland. But the thyroid hormones will still be low because the thyroid gland is not functioning because of this autoimmune disease. So we have in the histology, you will have infiltration of the inflammatory cells, lymphocytes, a lot of germinal cells, white blood cells because of the destruction, and fibrosis here and there. There will also be specific cells called Hürthle cells, which are pink in color and very clear in color, as you can see from the normal cells. This is specific to Hashimoto because it's autoimmune, and this is causing the cells to kind of be abnormal in that way. Now, if you see something that is inflammatory without Hürthle cells, then that is not Hashimoto, and that can be a normal inflammatory thyroid gland. So thyroiditis without Hashimoto, okay? So Hürthle cells is important for Hashimoto thyroiditis. What is the cause? Again, autoimmune. So they have antibodies. What antibodies? Most of the time, it's anti-thyroid peroxidase or anti-thyroglobulin antibodies. And that was the table that I was trying to show earlier with the antibodies here. So Graves' disease is mostly TSH receptor, TSH stimulating antibodies. If it's hypothyroidism, Hashimoto, it's most of the time these two, anti-thyroid peroxidase or anti-thyroglobulin, okay? If that gets asked in an SAQ, that is the most common types of antibodies for each disease. One hyper, one hypo. Now, these cells, these antibodies in Hashimoto, they will either cause stimulation of CD8 T cells, which will cause death of the follicular cells, or interferon gamma and macrophage will also kill the cells as well, or they will damage the cells through natural killer cells. Again, this is completely immunology, but just remember CD8, interferon gamma with macrophage, and natural killer cells through this process of antibody-dependent cell-mediated cytotoxicity. So all of this will essentially damage the thyroid gland, causing hypothyroidism. Okay, Hashimoto. Now, other causes of thyroiditis inflammation can be these three causes. Just remember, in inflammation, the thyroid gland is overstimulated at the first. So hyperthyroidism, you can see increase in thyroid hormones. Later, when the condition is treated and the thyroid gland kind of runs out of these hormones, you will see hypothyroidism. So because it ran out of all these hormones. Let's say then the thyroid gland is back to normal, you will have euthyroidism. So normal, it's very, very self-limiting. So the inflammation will be back to normal, so euthyroidism. So it can be in any state. When you measure the thyroid hormones, it can be in any state, either hyper, either hypo, either euthyroidism. It's not specific, but just know that the inflammation is there in the thyroid. Now, let's say this one is called subacute granulomatous decurvane thyroiditis. It's when you see multiple multinucleated cells, dying thyroid cells, a lot of plasma cells, inflammatory cells in general, but granulomatous, from the name, you will see a lot of granulomas or large cells, okay? So these kind of cells. That one is called subacute or decurvane thyroiditis. Vein and pain arriving. So this is very painful. The person will come with painful thyroid gland and at the beginning symptoms of hyperthyroidism, and then later it will be hypo, later it will be euthyroid. But at the beginning it will sometimes it can be hyper. Just remember painful tender gland. Like regardless of the result, they will have fever, it's inflammation at the end of the day. And one of the triggers is viral infection. So any of the viruses, common virus can cause pain in the gland. That is immediately your diagnosis. So yeah, this is the hyperthyroid phase. They can have elevated thyroglobulin, and ESR, the inflammatory marker, will be high. But if you, so we'll get to this in a bit. So ignore that for now. Let's move to this one. So silent lymphocytic thyroiditis. If you see lots of lymphocytes, lots of inflammatory cells taking over the thyroid gland without the Hürthle cells, then it's most likely this one, subacute or silent thyroiditis. So that means it's most commonly in a case scenario of someone coming postpartum. So, and they will complain of hypothyroidism or hyperthyroidism in that sense. You will suspect this thyroiditis. Lots of lymphocytes, lots of germinal centers without Hürthle cells, without fibrosis. So yeah, and that is in this case, it is painless. So painless, this is painful. The last one is fibrosing radial thyroiditis. You will see a lot of fibrosis, fibrosing structures, compressing. They will be difficult. There will be difficulty in speaking, in swallowing because of the extensive fibrosis. It's very, very hard mass of the thyroid. So these two at least they are normal. Like they're not hard. They're just soft thyroid. One is painful, one is painless. This one is hard, and it will be very like confusing with the thyroid cancer. So you always have to take biopsy to rule out cancer. And if you see this much fibrosis, then it's fibrosing thyroiditis. It's just an inflammation causing the fibrosis. So you will see that is the prominent feature in this thyroiditis. So if the person, another cause of hypothyroidism can be congenital. If the baby has dysfunctional thyroid gland from the birth, so that is called cretinism. This condition comes with a lot of other like symptoms. So let's say large tongue, protruding tongue, umbilical hernia, pot belly, growth retardation. So all of this together is called cretinism, and the baby like they will also be very, very severely mentally retarded as well due to impaired development. So in the development of thyroid gland in the womb, let's say there was something wrong. So the thyroid gland is not produced, right? So that means it's also causing the baby to have like neurological defects because the thyroid gland is important for the CNS. So again, because the thyroid is not being produced in the womb, it will cause severe mental retardation and all these features together combined. Yes, the severity, if there is maternal thyroid deficiency before the development of thyroid gland, it will cause severe mental retardation. But if this happens after, if the hypothyroidism happens after the thyroid gland is produced, then it still allows normal brain development. So it depends, this factor is dependent on the development of thyroid gland, or so criticism is formed if there is deficient or dysfunctional. The thyroid disorder, let's go into lab tests. So before we go into structural lesion, the lab tests, in any case, if someone is coming with hyperthyroidism or hypothyroidism or any thyroid symptoms, the first test that you do again is TSH level and then T4, T3. So TSH in hyperthyroidism will be low. TSH, if it's just a structural lesion, it will be normal. If it's hypothyroidism, so the thyroid is not producing, TSH will be high to stimulate that. Now, in the case according to thyroid, the TSH gland, according to TSH level, if it's low, you suspect hyperthyroidism, and you can go on to further tests. So things like radioactive iodine uptake scans. This is important because all the time, if the person is coming with hyperthyroid symptoms, the TSH is low, the next step should always be radioactive iodine uptake scan. This will show whether it's a nodule problem, whether it's a problem all over the thyroid, like Graves' disease, or just simple inflammation of the thyroid, like thyroiditis. You can also do next steps like thyroid ultrasound can be done here as well, but it's just to image or see the nodule, and thyroid antibodies. So in Graves' disease, it was anti-TSH antibodies. In Hashimoto's, it was anti-thyroid peroxidase and anti-thyroglobulin. So you can test these out as well. In that case, let's say the radioactive iodine uptake shows a nodule that is very suspicious of cancer, you can go ahead and do fine needle aspiration. So you take to see it under the microscope if it's cancerous or not. This is a table of showing radioactive iodine uptake. If it's high, you have these differentials of overproduction of hormones. If it's low, it can be due to other causes like externally taking thyroid hormones, follicular, okay, we'll get back to this, but technically in your exam, it will be thyroiditis. So the inflammation, these inflammatory conditions of thyroid will have low radioactive iodine uptake. Why is that? It's because the thyroid is overactive. It's in inflammation mode, you can say, and it's secreting all the hormones that is inside the thyroid. So it will be empty of thyroid in that scan. So these are the scans, okay? So in thyroiditis, it will be empty, or it will not show up at all, because it's, again, inflammation, the hormones are getting out of the thyroid, it's running out of thyroid hormones, and that's why it shows up like that. If it's high, you have multiple causes, which we'll get into in the next slide. So that if I hope that's clear, hyperthyroidism, in any case, you start with TSH. If hyperthyroidism, you go to radioactive iodine scan or antibodies, measure the antibodies. If it's structural lesion, if the TSH is normal, the patient is just complaining of dysphagia, difficulty swallowing, difficulty speaking, it's just a mass in their neck, you go ahead and do thyroid ultrasound to see where is the mass and what is the mass. Then you do biopsy by fine needle aspiration, which is the best test to diagnose. So once you do that, once you take the biopsy of this mass, it can look cancerous, it can have cancerous-like lesion, like follicles. It's better to take it out, better to take the whole thyroid out. If that biopsy shows thyroiditis, again, if it's thyroiditis in the normal state or euthyroid state, you don't need to take it out because, again, it's inflammation, it is self-limiting, it will die down with once the infection dies after the postpartum period or just after the trigger is removed. So that is structural lesion. If it's hypothyroidism symptoms and the TSH you measured is high, which was the first step, you immediately treat it with thyroxine, levothyroxine. You don't need to do further tests because there is no other treatment, right? Like it cannot be a cancer that is underproducing thyroid. So it's less likely to be dangerous. You don't need to remove the thyroid. You can just replace the levothyroxine. You can do thyroid ultrasound antibodies, but it's not necessary because all the treatments will be the same. It's just to replace the thyroid. So this is a good diagram from UWorld. So first you do TSH level and thyroid ultrasound. If it's normal or elevated TSH, which is hypothyroidism here, normal or high, you can go to fine needle aspiration to take it and to see whether it's cancerous or not. If it's low TSH, which is hyperthyroidism, remember this one, because the thyroid hormones are high, TSH is low. The next step you go forward is with the radioactive iodine uptake. If the radioactive iodine uptake is dark, that means it's hyperfunctional nodule or hyperfunctioning part. That is most likely safe because you can treat the hyperthyroidism according to the causes. But if the nodule or the uptake is cold nodule, or we say hypofunctioning, like let's say cold nodule, like for example this one. So it's there's no uptake, right? So we call it like there's no increase in uptake, but it's still producing hyperthyroidism. So in that case, you are very concerned of cancer. So cold nodules like these, you should be suspicious of cancer, and that's why you can do fine needle aspiration, take it out and see if it's cancerous or not in the slide. Now, okay, so cold nodule, this one is cancerous. It could be due to cancer, it can be due to any other lesion, but do FNA to rule it out. If the uptake is all over the gland like that and hyperfunctioning, that is Graves' disease, because again, diffuse is Graves' disease, specific for Graves. If it's cold nodule and hot nodule together mixed, this is called toxic multinodular. So multiple nodules, and it's very toxic. It's causing hyperthyroid symptoms. If it's one nodule and its uptake is high, then that is hot nodule, like that. Okay, so you can just treat it. You don't need to aspirate it or anything. So that one is hot nodule. This is toxic multinodular, and that one is cold nodule. So different scenarios. If one lobe of the thyroid gland is hyperfunctioning, let's say, and the other gland is not there at all, this is called autonomous nodule. So the whole lobe is kind of like a nodule that is hyperfunctioning. Again, if there is nothing in the uptake, we are suspecting nothing in the uptake plus hyperthyroidism, low TSH, we are suspecting just inflammation, just simple inflammation. This is another picture from your slides. So diffuse uptake is Graves. Multinodular goiter is multiple nodules being like uptaking the scan. So this and this is the same, right? So autonomous nodule, it can be due to follicular adenoma. So adenoma is like a tumor and hyperfunctioning tumor, okay? But still not uh, not as bad as cancer. So tumor is benign, more of benign condition. So we will get back into that later. So adenoma, the name adenoma is benign. When I say cancer, it's more cancerous, which happens with the cold nodule. And then with no uptake, that is thyroiditis. Okay, if it's painless, if it's painless, silent. If it's painful thyroid gland, it's subacute or decurvain. Yeah, and so on. The different types of inflammation. Okay. The treatment for hypothyroidism is very simple. You replace it with the thyroid hormone. The treatment for hyperthyroidism can be by medication. You can give things that will stimulate the production of thyroglobulin, the T3 and T4, which is in the pharma lecture. If you want to treat the hyperthyroidism causes like sweating, palpitation, things that are affecting the patient like here and now, you can give them beta blockers because the beta blockers will kind of calm them down, like it will reduce their sweating, anxiety, and so on. But this is in the moment. Over long term, you should use other anti-thyroid medication. You can also give them radioactive iodine to destroy the overproduction of thyroid by overloading the thyroid gland, or surgery. So surgery, in your lecture for the surgery, you can either do total thyroidectomy, total removal, or hemithyroidectomy. So removing half the thyroid gland, depending on where the nodule is. If it's Graves, obviously total. If it's like a nodule, if it's like a cancer, you can do hemi. Now, what are some of the complications you should look out for? So bleeding, you should look out for bleeding, things like nerve injury and infection. If the person underwent thyroid surgery and they immediately feel like they cannot breathe or there is swelling here rapidly, it means there is bleeding within that space. So it is important to release that bleeding by cutting it open again and let the blood go out. So there must have been an injury in the artery, and maybe the surgeon didn't find it then. So when they closed it, it kind of accumulated there. So it's important to look out for those signs post-operative, okay, post-op thyroidectomy. The nerves that can be injured are recurrent laryngeal nerve and external branch of superior laryngeal nerve. And if the recurrent laryngeal nerve is affected, there will be hoarseness of voice. If this is affected, then there will be monotonous voice. So they will lose their ability to do high-pitched voice. Post-operation, check calcium levels, because we'll get to parathyroid in a bit, but calcitonin, all these can be affected. So check calcium, check thyroglobulin, check and calcitonin as well, okay, to see if they are not affected or not after the surgery. Okay, so this question is showing someone coming with palpitation, heat intolerance, weight loss, so causes of hyperthyroidism. Fine tremor is noted. The first thing you do, TSH. TSH in hyperthyroidism is very, very low. What is the next step in management? You are suspecting hyperthyroidism. The next step in management should be radioactive iodine scan to see the different causes of hyperthyroidism. Now, the next one is symptoms of hypothyroidism. The patient coming with fatigue, difficulty performing activities, and so on. First thing you do is TSH. But I think they did all that, yes, and they saw that the biopsy, okay, so this is a female coming with hypothyroid symptoms. Again, remember the most common cause of hypothyroidism. What would the biopsy look like? The most common cause is Hashimoto thyroiditis, which is having intense inflammatory infiltrate with active germinal centers. So very, very inflammatory picture of the thyroid, plus Hürthle cells. I should mention that here. But yeah, it's not giant cells, not the thyroiditis, not follicular hyperplasia, because that is hyperthyroidism, not dense fibrous tissue like the fibrosing thyroiditis, and not branching papilla, sorry, which is a cancerous lesion, which we'll come to later. So the answer is Hashimoto thyroiditis. Which of the following is the most likely a cause of edema in this patient? So this is the picture we saw before. They have intense inflammation and so on. What is the cause of the mixed edema? Is because of the accumulation of glycosaminoglycans. What antibodies will be present in Hashimoto? Antithyroid peroxidase and or antithyroglobulin. Okay, so anti-TPO is the most common in Hashimoto. Now, thyroid disease, we said hyper and hypo. Let's talk about structural causes. It can be cancerous or not cancerous. Not cancerous lesion is the fibrosing thyroiditis. Again, it's in a red box because it signifies inflammation of thyroid. What about cancerous lesions? It can be adenoma, which is benign, thyroid adenoma, or less common is carcinoma, cancer of the thyroid gland. The cancer and the adenoma, they're both differentiated by the invasion of the capsule. So the thyroid gland has a capsule. If that is invaded, it is carcinoma. If it's not, it's adenoma. If there is vascular invasion, carcinoma. If it's not invaded, adenoma. Okay, that is the baseline. Now, in the carcinoma, we have papillary cell carcinoma, most common, follicular cell carcinoma, medullary cell carcinoma, and anaplastic carcinoma, which we'll get into. And this definition, the thyroid can be as big as this, but remember that there can also be physiological causes, and such as food intake, iodine deficiency. They can all cause this enlargement or goiter, okay, which is the term for enlargement. Okay, so if it's thyroid adenoma, so you can clearly see the capsule. Make sure in histology, they have to always check if the capsule is invaded or not. And here it's clearly not, right? Because the capsule is well seen. There's no invasion of the capsule. There's no invasion here. The cells look okay. They're not invading this capsular line. There's just maybe an increase or proliferation of the cells, but not really, and dying cells, but not really invasion. So that's still adenoma. It's still benign thyroid adenoma. Again, no invasion, no invasion. You can sometimes have proliferation of Hürthle cells again, but they're most, oh, sorry, can you just go back? Yeah, so Hürthle cells, which are the pink cells. So pink cells can increase and there can be nuclear changes. So Hürthle cell with nuclear changes or atypia, like darkening of nucleus, increase in division of the cells, all of this is pointing to thyroid adenoma. It's not the Hürthle cell that we saw with the Hashimoto's, okay? So again, main thing is it's not invading the capsule with the nuclear changes, with proliferation of these cells. This is thyroid adenoma. It's most commonly, again, benign, and you should take it out just to see if it invaded the capsule or not, just to rule other causes out. What about cancer? So thyroid cancer is very rare, but you can divide it into cancer that has good prognosis or bad prognosis. Good prognosis are two types, papillary cell, which is the most common, and follicular cell. From the name, papillary cell will have projections like papillary projection, finger-like projections in histology as well, with a fibrovascular stalk. So it is very they have a very good blood supply and a fibrovascular core to support this cancer. If you only have papillary projections with no fibrovascular stalk, it will be most likely inflammation, okay? So let's say you have this. If you look closer, you can see cells that are very light in color that looks like eyes, like empty eye, like cartoon eyes. So that's why they call it orphan Annie nuclei. So empty, like white nuclei, or nuclear groups here and there, inclusion bodies, and something called Samoma bodies, which are calcified remnants because of all this cancer process. These cells, if you see empty nuclei, that is your go-to for this diagnosis, papillary cell carcinoma. It's very good prognosis. You can take it out and it will be cured. And it is the most common cause of thyroid carcinoma. The second one is follicular cell carcinoma. As you can see, again, carcinoma means invasion. So here you will have invasion of capsule. Same here, invasion of capsule, invasion, invasion. What is different from this is they will not have the clear nuclei, and they will not have, they will have from the name, follicular cell. So all of the cancerous cells will look like follicular cells, the normal thyroid follicle cells, except the nuclei will be hyperactive, like they will have nuclear changes, atypia, darker nucleus, trying to divide a lot more. But they will not have these features of papillary cell. They will only resemble follicular cell, but more in number. Remember, this was also in follicular. So the other ones, the inflammation of thyroid and Hashimoto's, they had lots of inflammatory cells. Very, very different picture from carcinoma. Carcinoma is the cells themselves are proliferating. Okay. Now, the carcinoma with bad prognosis are medullary cell carcinoma and anaplastic. Anaplastic cell carcinoma is the most severe aggressive type, and they will have metastasis everywhere in the body. That's how you can tell that this is anaplastic and very, very severe condition. They will have weight loss very rapidly as well. So in this picture, in the anaplastic cells, even the nuclei are very strange. They're very dysplastic, pleomorphic giant cells, very large, a lot of spindle cells, abnormal looking cells. So nothing like the normal thyroid follicular cells, and mixed cells of all kind. And when you do thyroid markers, thyroglobulin, which is normally found in thyroid, will be negative, so no more. And other epithelial markers which are not supposed to be there will be positive. Okay, so CAM, AE1, and so on will be positive because, again, it's just abnormal cells everywhere. What about medullary cell carcinoma? Medullary cell carcinoma are cancers of not of the follicular cells of thyroid, but of the calcitonin secreting cells, which are parafollicular cells or C cells. Parafollicular cells, calcitonin cells, which secrete calcitonin. That is the cancer in this case. What do you see in the histopathology? You will see polygonal cells, a lot of amyloid pink deposits everywhere. That is the hallmark of this cancer. And when you stain it with Congo red stain, it will appear apple green. So Congo red, and when you polarize it, which has something to do with the light, you will see it turn apple green. Okay, that's the hallmark of this medullary cell carcinoma, again, because of their amyloid deposits. Okay, and the cells that are being secreted more here are not the thyroid ones, but the calcitonin from the parafollicular cells. Okay, so this is a summary of the genetic abnormalities for Graves, Hashimoto's, and so on. The important thing, again, for this one is medullary cell carcinoma and the carcinomas in general. Medullary cell carcinoma can be due to RET proto-oncogene or the MEN2 syndrome, which was also present in the pituitary gland, if you remember. What about these three, papillary, follicular, anaplastic? So for these, we have to look at the receptor of the thyroid gland. The normal receptor for the thyroid gland in a follicular cell is like RET gene or RET channel. This, once TSH comes and attaches here, it will undergo a lot of like what do you say, communicate, I forgot the word for it, but basically a lot of cell cycle signaling. So it will signal other components to go to the nucleus of the follicular cell in order to make thyroid hormones. So what is this pathway? We have RAS pathway. We have so RAS is the common component. Then the RAS will send signals to MAPK pathway, which is this one, or PI3K pathway, which is this one. Okay, so this MAP kinase pathway and PI3 kinase pathway both will go to the nucleus and stimulate production of thyroid hormones. If you have papillary, so accordingly to these cancers, they all have their own genetic like mutations. So the papillary carcinoma, which is the most common one, will have mutations in the RET, the channel itself, or the MAP kinase pathway in something called the BRAF. So BRAF, whenever you have this, it's a bad prognosis of papillary carcinoma. So B and B for B. Okay. If the mutation is only in the RET channel, then it's a good, much better prognosis than the BRAF gene mutation. Just remember that. Follicular carcinoma can have mutations in the common the RAS component. So follicular and anaplastic can be here. And the PI3 kinase. It's not this pathway at all. The MAP kinase pathway is only for papillary carcinoma. Follicular is PI3 kinase pathway. Now you can have mutations in RAS, PI3K, P10, loss of P10, or the overall in the nucleus itself, you can have the mutation. All of these will be for follicular carcinoma, this pathway. And the same way for anaplastic as well. So anaplastic and follicular are very similar. The only difference is for follicular is the genetic mutations inside the nucleus. But just remember this two as the same. Okay, so it's important to know the genetic mutations because those can be asked and to differentiate the carcinomas based on the mutations. Again, a question, I won't like pause here, but just to explain, if you see dense fibrous tissue and swelling of the neck, someone complaining of hoarseness and so on, it is most likely thyroiditis. It's a structural lesion, again, because of the dense fibrous tissue, okay? 14-year-old girl, again, notice gradual neck enlargement. TSH, the first thing you do is normal, but the thyroid gland is diffusely enlarged. Diet, again, remember, this goiter can be due to diet changes, iodine deficiency. So which of these foods can cause goiter, which enlargement of the thyroid gland? This, I didn't mention it before, but it's in your lecture. And things like cabbage, Brussels sprouts, all this family will cause goiter because it has a component of iodine which will stimulate the growth of thyroid gland. Now, a 22-year-old woman again came with features of a small bump on the right side of her neck. It's painless, and the radionucleotide shows uh, that the nodule does not absorb radioactive iodine. So it is, wait, I'm just trying to, yeah. Okay, and then they did fine needle aspiration. Remember, cold nodule, you always do fine needle aspiration to rule out cancer. And the cytologic features are those of follicular neoplasm. Which of the following lab is most likely present in this patient? So if they already told you the diagnosis, right? Follicular carcinoma. In that case, would the antibodies be high? No, because it's not an autoimmune, it's a cancerous process. It's a structural lesion where the TSH is, or supposed to be, normal. Okay, so follicular cancers, adenoma will have normal TSH and it will not affect the thyroid hormones, unlike the hyperthyroidism or hypothyroidism. A 44-year-old again feels a small lump in her neck, painless and firm. And you can see all these lab results are normal. There's nothing abnormal. They did fine needle aspiration of the thyroid gland. What is the most likely diagnosis? Okay, so if you have someone coming with a firm painless mass, TSH is normal. It's again a structural lesion. The next step you should do is fine needle or thyroid ultrasound, right? So once you do that, it will show some sort of cancer or adenoma. So which of these adenoma or sorry, carcinoma are the most common? If it's not mentioned, go with the most common type, which is yeah, and they give you the picture. So this is the picture of the like from the answer, but if you see what you see here, you see clear nuclei, orphan Annie nuclei cells. You will see a lot of nuclear atypia, a lot of activity in the thyroid gland, which is not normal. So it is most likely papillary carcinoma. Again, hallmark is the clear nuclear cells, okay, which was the orphan Annie nuclei. If someone is coming with, again, I won't read the whole question just because it's a recording, but if someone is coming with painless, large, tender mass involving the right thyroid, it's not yet inflammation because we have to rule out the rest, right? So fine needle aspiration shows pleomorphic spindle cells. He's coming with hoarseness and everything happened for the past 3 weeks. So it's very quick and very severe. And you can see that the mass is infiltrated to the skeletal muscle. So it's already very bad in 3 weeks. So what do you think? With metastasis, it is anaplastic carcinoma because it's the most aggressive type of cancer. Okay, we're now finally in the parathyroid gland. Parathyroid is behind the thyroid gland. It's normally like this. It has chief cells and oxyphil cells. So chief cells and oxyphil cells, the chief cells will produce PTH, which is the parathyroid hormone. What is the function of the PTH? Is to increase calcium in our body. So let's say that the calcium is low for some reason in our body. The parathyroid will release PTH to act on 3 different organs, which is the small intestine to absorb calcium back into the body, which is the kidney to increase reabsorption of calcium from the fluid and the urine, and the bone. The bone will start to release or break down to release calcium in the blood. Again, all of this is to increase calcium in your body. High PTH, high calcium. Okay. Now, how does it do that? There are other things like calcium activates the enzyme in the kidney, which will activate vitamin D. Vitamin D is needed for absorption of calcium in the small intestine, and so on. It is also a phosphate thrashing hormone. So PTH, phosphate excreting hormone or phosphate thrashing hormone, is a mnemonic just to let you know that PTH actually increases excretion of phosphate instead of reabsorption. So increases phosphate excretion from the kidney and increases calcium reabsorption. This is just to explain the functions of parathyroid hormone, and all of this is to increase calcium. Its main priority is calcium. It does not care about phosphate, okay? Now, parathyroid disorders, again, can be hyperparathyroid or hypoparathyroid. Hyperparathyroid can be due to, so if let's say the parathyroid is overfunctioning, you will have high calcium in the blood. If it's not functioning, you will have low calcium in the blood, so hypocalcemia. The hyperparathyroid can be due to parathyroid adenoma, again, which is the most common one, or hyperplasia, which is so there's 4 glands in the thyroid. All these, in the parathyroid, all these glands will be growing too much, so hyperplasia. Whereas in adenoma, it's only one of these glands that get bigger. There can be parathyroid carcinoma, again, very rare. Secondary causes of hyperparathyroidism can be due to something causing the parathyroid glands to overproduce. So primary problem means that the parathyroid glands were not, like, there was something wrong with it, whereas in secondary, something is wrong here that is stimulating the production of parathyroid. So it can be deficiency in vitamin D, deficiency in chronic kidney disease, for example. So all of these will cause low calcium, which will make the parathyroid gland produce more parathyroid hormone. So you see this renal failure is the most common type of secondary hyperparathyroidism. These are the symptoms of hyperparathyroidism. Again, you will find someone with bone pain, fractures, because their bone is constantly being broken down to release calcium. You will have, let's say, renal stones, because again, kidneys being overworked. Constipation, gallstones, can be depression. With hyperparathyroidism, you can have short QT interval because, again, the ion changes and so on. Ionic changes can affect the heart. You can have calcifications due to hypercalcemia. Secondary, okay, so hyperparathyroidism caused by secondary, like renal failure, let's say, can cause calcification everywhere else in the body, including blood vessels. So that causes something called calciphylaxis, which is calcium deposits in the blood vessel. That is more specific for secondary because it's more general over the body rather than the problem being only in the gland. Okay, so secondary due to renal failure is very severe. It can cause a lot of bony changes and so on. But this is, yeah, specific for secondary. Let's say in hypoparathyroidism, you can have less production of the hormone due to surgical removal of the gland or just genetic mutations that is not causing the gland to function, or congenital absence of the glands. Now, the symptoms will be due to hypocalcemia. You can have tetany, so numbness, tingling, spasm, seizures. All of these are because the body has not enough calcium. You can have mental state changes, other changes of, again, intracranial manifestations like Parkinson, papilledema, calcification of lens. So this can happen even if it's hypocalcemia because your parathyroid hormone is not being like produced from here, but it's your body is kind of trying to make up for that loss, like the hypocalcemia. And what else? Dental abnormalities. So usually, yeah, Okay, just ignore that. Just remember the symptoms of this, that even with hypocalcemia, there can be calcification. Dental changes, so weak bones, weak teeth can happen. In hypoparathyroidism, you can have prolongation of QT as opposed to this short. Okay, so here it's longer with hypo. The two most important signs, even if you don't remember these symptoms, the two most important signs is Troisius sign and Schwottek's sign. So let's say this mnemonic is very helpful. If you stroke the facial nerve of the cheek here, in the cheek, they will have like twitching of the facial muscles. That is because of hypocalcemia. And that is called Schwottek's sign, so C for cheek, okay? What about the Troisius sign? Troisius sign is when they put a blood pressure cuff on their arms and you try to, like, it compresses their nerves here. The arms will start twitching, okay? So that happens when they have a blood pressure cuff here or compression of any kind of on the nerves here. So that twitching is called Troisius sign of the hands when the upper arm is compressed, okay? So that happens due to hypocalcemia. Again, calcium deposits can still happen because the body is reacting or they're trying to break down the bones and everything to increase the calcium, which is why you have these manifestations. Okay, so parathyroid can be, again, if we're talking about hyperparathyroidism, it can be due to adenoma or carcinoma. Adenoma is more common. You will have just proliferation of the parathyroid cells. So you will have proliferation of chief cells and occipital cells everywhere in the gland. And it's most likely one of the glands is affected and without invasion of the capsule and so on. One of the signs of hyperparathyroidism is osteitis fibrosa cystica, which is the breaking because of the breaking down of bones. Because your bones are trying to break down, you will see a lot of pink like deposits. This is in the bone, by the way. But you will see a lot of osteoclasts trying to break down that bone, and that's why a lot of also a lot of activity, a lot of breaking down of bone can be seen when you put it on the slide. In this case, when there is trauma or fracture of the bone, there is a lot of activity, like I said, right? So there is a lot of blood supply. That blood supply kind of spills and makes an accumulation of blood in the bone, and it causes this condition. So osteitis fibrosa cystica, because of the blood accumulation, because of the hyperactivity of the bone itself, inside the bone, okay? Due to trauma and everything that causes disruption. Parathyroid carcinoma is very rare. What can you differentiate? What you should know is that there's invasion of the capsular or the vascular, like vascular invasion or capsular invasion with metastasis. And sometimes you will see thicker capsule than here. So here the capsules are normal. It's just proliferation of glands, benign adenoma. Carcinoma, thick capsule, and invasion of, you can see invasion of the cells inside the gland. And it's very severe. You can have metastasis as well. Oh, okay. Now, for, for genetic abnormalities of parathyroid, you will see, this is a summary, and it can be autoimmune, autosomal dominant, affecting the receptors of the parathyroid gland itself. What is more important for you to know are these two lab results. So you can have primary and secondary, like I said, right? So in hyperparathyroidism is more important than hypo. This is for hypo. For hyper, if it's primary, you will have either way, primary, secondary, or tertiary hyperparathyroidism, PTH will be high, right? What about the calcium? So primary is a problem in the parathyroid gland. So the calcium will be, the PTH is the problem, it's high, so calcium will be high, hand in hand. Phosphate, again, it doesn't care about phosphate. Phosphate is low. Vitamin D is normal or low anyhow. Again, most common cause of primary hyperparathyroidism is adenoma. Sometimes it can be hyperplasia, sometimes it can be carcinoma. Secondary hyperparathyroidism can be caused by renal failure, is the most common cause. So if the kidneys are failing, then that means the calciums are not being absorbed, right? So the calcium will be low. It is the problem of this condition. So calcium is low, phosphate is high because phosphate now cannot be excreted because the kidneys are failing. So in that case, PTH is high because of the renal failure. The renal failure is causing low calcium to be in the body. This low calcium goes to the parathyroid gland to tell it to release more parathyroid hormone. Yeah, so that's mainly it. Just differentiate between the labs here. It's the complete opposite between primary and secondary hyperparathyroidism because of the calcium levels, okay? And because of the difference in causes. The last thing that I will finish this lecture with is the MEN syndrome. Just remember that there is a syndrome. So this MEN syndrome is affecting more than one endocrine gland, depending on the type. So we have MEN1, MEN2A, MEN2B. MEN1 is the one that causes pituitary adenoma, at the same time parathyroid hyperplasia and pancreatic tumor. So P and P and P in MEN1. This is a much easier diagram. So MEN1, 3 Ps, pituitary, parathyroid, pancreas. What about 2A? 2 Ps and 1 M. So that means, I'll explain. So parathyroid gland is still there as like the MEN1, but 2 Ps, so it will cause, pheochromocytoma from the adrenal gland and thyroid as well, but medullary thyroid carcinoma. Okay, remember we said medullary thyroid carcinoma can be as a result of MEN2A or MEN2B syndrome. So this is what we see here. Now, okay, so we said MEN1 is these 3 glands. MEN2A is these 3 glands. MEN2B is the pheochromocytoma, again, the same as this one. Medullary thyroid carcinoma, same as this one, but with mucosal neuromas. So there are other glands or nerve, like neuromas, tumors of the nerve sheath that can happen in this. So we will call that 3 Ms and 1 P from the pheochromocytoma. So this is MEN2B syndrome, and they can have Marfanoid habitus. So that's why it's 3M. So they will have long arms, long legs, similar to a Marfan syndrome. Now, okay, so these triads or this 4 also is very important. Why? Because if someone has symptoms of pituitary and they have some symptoms of parathyroid adenoma, you will suspect that they have something of MEN syndrome. And it will be specific to MEN1 because pituitary is only affected in MEN1. Let's say someone is affected with MEN2A, okay? They will have parathyroid gland, adenoma, hyperplasia, and they can have symptoms of pheochromocytoma, which is in your next other lecture with the adrenal glands. So they can have these 3 manifestations or 2 manifestations, and you will suspect that they will get the 3rd one later in the future. So it's very important to look out for these syndromes and to know the relationship. And for example, someone has pheochromocytoma and medullary thyroid carcinoma, then that means it can be either MEN2A or MEN2B. Only time will tell and only genetic testing will tell, right? Because if none of these are affected yet. I guess one important differentiating factor between these two is if the person is tall and they have long arms and long legs, it's more likely MEN2B. MEN2A is these 3, MEN1 is these 3. Okay, I hope that's clear. Just know from the mnemonic and hopefully it will be okay. Lastly, to finish off with some questions, these are all from all over the lecture, so let's start. So a woman coming postpartum presents with polyuria, polydipsia, so signs of hypopituitarism of diabetes insipidus, right? MRI reveals enlargement of the posterior pituitary. Which of the following is the most likely diagnosis? So if the posterior pituitary there is an enlargement, there is something there causing diabetes insipidus. And remember, postpartum. So most commonly, it's not anterior pituitary, so not Sheehan, not sarcoidosis, because it's not the most common. Craniopharyngioma, it's not likely that, because again, craniopharyngioma will have other sort of symptoms, and it's not common in postpartum. Pituitary macroadenoma does not cause diabetes insipidus as much. So the most common cause is lymphocytic hypophysitis. How do we know that, or how do we kind of lean towards that? Is because, again, postpartum. Just remember the age, the condition of the patient. And craniopharyngioma can present with DI, but it has specific age groups. So childhood, it can peak in childhood, and in very late adulthood. So not the 22. Okay. Okay. Someone coming with postmenopausal woman with bloating, early satiety. Um, okay. Yeah. So this one you can see. Okay. So there is an ovarian mass. Just remember, if you see something that we didn't take in this lecture, it's most likely metastasis to the ovary, metastasis to the abdomen. But basic idea, even if you skip all that and you read this line, malignant epithelial cells forming papillary structures with Samoma bodies. That means that the origin of all this cancer is from the thyroid. And where did we say we saw Samoma bodies? Was in papillary cell carcinoma. So that must have spread to all of this, causing all the symptoms. So like, why is papillary cell carcinoma that bad and presenting that severely? Due to a genetic mutation in which of the following, if you remember? BRAF. So B is for bad prognosis of papillary cell carcinoma. Okay, retinoblastoma is aggressive in pituitary, P10 is in anaplastic and follicular, and so on. Okay, so a woman coming to the clinic with complaints of fatigue, mild weakness, constipation. She also reports kidney stones, so symptoms of high calcium, hypercalcemia, pointing towards a nodule in the left thyroid. So it's not in the thyroid, it's in the parathyroid, behind the thyroid. Calcium is high and phosphate is low. Parathyroid is high. So that is a picture of primary hyperparathyroidism, because calcium is high, PTH is high. This is the picture with cells not invading the capsule, and the most common cause of hyperparathyroidism is parathyroid adenoma. Okay, oh, that's clear. Oh, sorry, I should have. Okay, let's read it. So a man coming with non-functioning pituitary, pituitary microadenoma. There is no compression, hypogonadism is treated, everything is okay, and it's not functioning. So the next step in management is to repeat MRI in 6 months, because if you read the other options, you don't really need to do surgery for something that is not affecting, non-functioning, okay? So transcranial, no need. Dopamine is for prolactinomas. Again, no symptoms. Yeah, and that's mainly it. I just wanted to show you that there can be different scenarios. If the person is not complaining and if their symptoms are being treated, you can just follow them up regularly, okay? Okay, last few questions. 22-year-old man comes to the office for neck mass. He first noticed a small nodule in lower neck, and which has enlarged over time. So we are talking now about thyroid. So physical exam shows 2 centimeter nodule in the right thyroid. There are multiple 4 to 8 soft papules on the lips and tongue. So this is something else. The arm span is exceeding the height. So tall man, and calcitonin levels are high. So parathyroid is the one that is affected, right? So do you see the relationship? He has a lot of symptoms from all over the body. So what do you think is most likely to develop in this patient, maybe in the future? So if you see here, what does it look more like? MEN1 or MEN2A or MEN2B? Because I said the figure, the Marfanoid status or habitus points towards MEN2B syndrome, and he has mucosal neuromas. See, parathyroid is affected. So he can most likely have in the future pheochromocytomas, which is this, right? Because mucosal neuromas is already in the question. This is already in the question. The thyroid, it can be, right? The thyroid nodule was already there. So the only thing that can happen in the future is pheochromocytomas. Just remember, it's a meant to be picture. Once you take in the adrenal lecture, you will see that pheochromocytomas presents with episodic headaches. Episodic headaches, episode spikes in blood pressure, and so on. So this is more pointing towards meant to be. That is what I want you to know. So what is the most likely finding in the thyroid? According to meant to be, it should be medullary thyroid carcinoma, right? Of the parafollicular cells in the thyroid. So how does that present with? That will come as apple green bifurcations with Congo red positive deposits. Okay, so that is specific. If you see Congo red stain and that becomes green under polarized light, that is medullary cell carcinoma. Okay, thank you so much, and I hope that benefited. This is the QR code for the feedback. And I wish you all the best in your exam. If you have any questions, please feel free to reach out to me anytime, and best of luck.